So welcome everyone to the first Humanitarian Task Force webinar. Thank you all for joining, we appreciate it. For those who might not know me, my name is Jessica DeMulder and I'm the Senior Program Manager for PGY and co-lead the HTF together with Ashish. So as most of you know, we've been working with HTF Humanitarian Task Force liaisons. We are 16 across all of the council programs, regions, and country offices to ensure that the Humanitarian Task Force is a platform for information exchange and collaboration across the council on research related to COVID-19. And one of the commitments of the task force is to create space for collective internal learning opportunities that aim to foster innovation and cross-collaboration across the Council on COVID-19, as well as other humanitarian topics. So for today's webinar, Corinne, if you could move to the agenda, the next slide. Thank you. So the HTF today, we aim to hear more from talents that we don't often have the chance to hear from regularly. And for this reason, today's webinar centers the perspectives of 4 teams working on the ground in Bangladesh, Guatemala, India, and Kenya, who have been leading the coordination, analysis, and data collection of the COVID-19 research that has been happening over the past few months. But we wanted to first hear a few welcome remarks from Twy, who oversees the Humanitarian Task Force in PGY. We'll then hear the 4 presentations consecutively. They're 8 minutes each, followed by a 20-minute discussion that will focus on research utilization, which will be moderated by me and Ashish, and then we will wrap up and conclude. So again, if you are just joining, please ensure your microphone is on mute, enable your video if you want to, add your pronouns to your name if you're comfortable. And with that, I turn it over to Twy to provide the welcome remarks.
Thank you, Jessica. Good morning, everybody. Good afternoon and good evening. It's great to see about 70 people have joined this meeting, and it shows that there's an eagerness and to kind of collaborate and learn. So I really appreciate that. I'm Twy. I oversee the Poverty, Gender, and Youth program, and just a little bit correction. Ashish and Jessica oversee the Humanitarian Task Force. I just advise. So all responsibility is up to them, and all the success is also them as well. I just want to kind of say that it's been very inspirational for me to have seen how the COVID-19 research have evolved over the past, I guess, 3 months now. It seemed like 3 years, but it's only been 3 months. Early in March, when the pandemic really kind of hit, we brought a group of people together in PGY, well, across the council, but PGY kind of put out a call to anybody who's interested in COVID and just really think about how do we utilize our infrastructure across our country offices and elsewhere, and our data analytics and public health and social behavioral science, as well as biomedical science. There were some CBR folks on that initial brainstorming call on how do we help and contribute to response and to like change the course of the pandemic. And I think, you know, personally, we all have to innovate on how we operate during social distancing, but also professionally, many of us have to innovate how we work, how do we manage work-life balance. So where we are today is about 14 projects across, I think, 10 countries on COVID-related research. And so I think what's come out of this is really interesting for me I hope the conversation today is not so much about the result of the findings, but it's about how did we get here? How do we innovate the way we work? How do we mobilize team and change the way we work? How do we influence policy? We've seen so many of our research been cited in news, policy document, and being used directly by policymakers. And then the other really important question is that we always talk about the importance of embracing the One Council approach. And so I'd love to kind of hear how have we kind of leverage each other talents and utilize each other talents across country offices as well as across program. And much of that, I think I really love the team across different projects really buy into this data sharing and tool sharing on Dataverse. And that had enabled your colleagues across the country offices to utilize those tools. But we have about people from about 260 institutions across 80 countries have also used those tools, and they are from both leading research institution, UN agency, other NGO, but also some policy making organization as well. So I just want to say, I understand that it's require a lot of hard work, a lot of adjustment. So I really want to congratulate, but also really appreciate all of you. And I just want to listen and learn from all of you further. You know, I'm deep in it with some of you, but I'm not involved in all the projects. So looking forward to the conversation. Thank you, Jessica and Ashish, for convening this learning group. I really appreciate your leadership on this as well. Thank you.
Thanks so much, Twy. We will now move on to the presentations, but before we do that, we would like to briefly talk about how we will structure the discussion and some questions. So if you have questions during the presentations, please feel free to enter them into the chat box, and we will be compiling these questions and asking our PIs and our teams in the countries to answer them over the next day or so, and we'll be posting these answers on our SharePoint along with the recording of this webinar. We want to focus the 20-minute discussion at the end of our session today on themes of research utilization, and we hope that the questions that are discussed are around research utilization. If you have questions regarding points of clarification or specifics to studies, we ask that you put them in the chat box, and you can do so throughout the presentation. We will be compiling them as we go. So with that, let's get started with the presentation. The first team that will present will be Bangladesh, and Iqbal Ehsan and Ashita Haq will be presenting this presentation. Off to you guys.
Thank you, everybody. Can you see my slide?
Yes, go ahead.
Okay, thank you. Thanks to Humanitarian Task Force for hosting this important event and giving us opportunity to share some aspects from our recently completed first round of phone-based survey with adolescent girls during the time of COVID pandemic. Before going to discuss the study, let us talk something about the Bangladesh scenario. At first, I would like to say that in Asia, Bangladesh is currently number 6 in position in terms of total infected case. If you see the numbers is there. And the first case in Bangladesh was identified in 8 March. 3 people were identified. Among them, 2 men were return migrants and 1 woman was a family member of one of these 2. Infections remained low until the end of March, but it increases in April and spread all over the country, as you see in the map. But compared to other part of the country, our studied districts in the north side seems relatively less cases of infections, average below 200. And Bangladesh is currently going through the 4th stage of community transmission. Currently, we are doing around 15,000 tests under the monitoring and supervision of government agencies. And you know, the total population is 160 million in Bangladesh, and the total test is really very inefficient and not sufficient at all. And if you see this graph, you will see the increasing trend of infection and transmission of COVID across the time. You can see that we have conducted our first round of survey between 20 to 30 April, when the country observed larger scale of community transmission. our second round of data collection is ongoing. We will talk a little bit more about data collection in the next slides. We would like to focus on our study very briefly because the time constraint. The main objective of our rapid study was to understand the knowledge, attitude, and practice and needs of adolescent girls living in the rural areas in the time of pandemic. So rural areas, girls is our main focus, and this is totally adolescent focused study. And the location was 2 project sites in Bangladesh, 5 districts, and total sample was 959 adolescent girls aged 12 to 19 years. Mean age was 15 years. 81% girls were in school. Among them, 12% were married, and response rate was 68%. And we failed to, and the incorrect phone numbers is one of the main reason of low response rate. If we see the survey domain, we have actually focused a range of topics in our rapid survey, including knowledge about coronavirus, perception and practice like washing hand, wearing face mask, maintaining social distance, etc. We have also focused on mental and general health condition of the adolescents and member of their own family. Besides, we tried to cover the impact of countrywide lockdown on their education, social and economic life. As the survey is rapid in nature and the way of conversation was phone call, we limited our number of questions around 30 to 35 so that one interviewer can cover 8 to 10 interviews each day. The average time of interview was 22 minutes. And we have also added some additional question in our second round, focusing stigma, risk of school dropout, child marriage incidents, available services in the locality, mobility after lockdown. We tried to cover these things so that we are hoping that more useful information will be coming in our next round, and we will be able to compare between educational outcome, risk of child marriage, and other aspects of social and economic life of the adolescent girls. Now my colleague Ishita will carry on the rest of the presentation, and she will describe the survey process and other issues. Thank you.
Hi everyone, I'm taking it forward from Iqbal Bhai. Slide please. Yeah, so I'll be talking about the survey process now. So to conduct the survey, we recruited 11 interviewers, which includes some of our program mentors as well, to collect the data. And while recruiting, we kept in mind that our interviewers and respondents are from different areas to minimize any bias associated with data collection. And one interesting feature is that our interviewers collected data using 2 devices at the same time. Interviews were conducted over one phone and data were recorded in Survey CTO platform using another device, mostly a smartphone. Now let's look at the training process. We conducted the training over Facebook Messenger because we also shared survey materials prior to the training so that interviewers get enough time to conceptualize the questions and the guideline. Also load airtime and data back to interviewers' phone prior to the training. The next slide, please. Now let's have a look at how we administered our phone-based survey. So since our survey respondents are adolescent, majority did not own a phone and were reached through a household phone, mostly of their parents. And in terms of consent seeking, we followed a 2-step consent procedure. In the first step, our program staff obtained permission from the parents. And in the second step, we took consent from girls through a return SMS. As you can see that in this snapshot on the left, the blue box is the preset text that we sent out to the girls asking if they agree to participate. Then they have to send a reply writing 1 and their name as depicted in the white box. And also for each interview, we set a prior appointment according to respondents' convenience just to ensure their availability. And one additional finding I would like to here is that the phone survey cost is much lower than in-person survey cost for us. We calculated one phone survey cost is about $2, whereas in-person cost is about $10. So it is very cost effective. So now let's move on to the dissemination strategies for policy influence. Just to highlight that adolescent surveys are important to draw attention to adolescent policy formulation, especially on education and child marriage during COVID pandemic. And this is especially because adolescents are a vulnerable group of population, yet very much understudied. Hence, these research findings can be very effective in providing information to interventions that are directly relevant around the lives and livelihoods of our adolescents. But one thing that we also need to note here is sometimes donor review can be time consuming, and that can eventually delay the dissemination process. And it can be critical as crises like COVID essentially require timely attention. And finally, we need to acknowledge that the increasing COVID crisis situation, especially that of in Bangladesh, our adolescent survey is the first of its kind in the country, can be utilized to improve adolescent programs. For instance, our current partner, UNICEF, has committed to utilize our findings to revise their intervention strategies as needed for the adolescent girls during and after COVID. So this is very encouraging for us. And that is all from my end. Thank you.
Thank you, Bangladesh team. Now we will move to the second team, the Guatemala team. So I'm handing it over to Brian and Angel.
Thank you. Great. Hi, everyone. I'm Brian. So next, please. Okay. So Guatemala's share of indigenous people is one of the highest in Latin America. We prioritized indigenous populations because we expect that they will be disproportionately affected by the COVID-19 outbreak. Since before the pandemic, indigenous groups were already overrepresented in social and economic indicators that denote vulnerability. We collected data in 10 communities where the Abriendo Oportunidades program has been implemented. The key informants were household heads, community leaders, municipal officers, frontline health workers, AO mentors, and teachers. We completed 144 surveys with a participation rate of 88%. We collected data in the middle of April. The survey domains were knowledge, practices, and gaps in needs. Next, please. Okay. Having an updated phone directory of both active and past mentors, as well as indigenous authorities from the communities where the AO program had been implemented, was crucial in this task. We also had a pool of mentors and local university students trained in data collections who were familiar with our approach to data quality. For example, we had some mentors who participated in the AO RCT data collection efforts. So this recent experience collecting large surveys among indigenous girls and mothers made things easier. Next, please. So some of the challenges we found was that our key informants belong to 5 different ethno-linguistic groups, and this required, in many cases, real-time translation, which made calls longer. And since we were calling some informants who lived in remote rural areas, sometimes they would lose their phone signal and we will have to repeat some questions and or call again. Some informants complain about the time they invested in the survey over the phone, and this was especially connected to managing respondents' expectations because no compensations were offered. And finally, respondents' unfamiliarity with pandemic concepts such as quarantine and self-isolation required us to repeat some questions and answers more time. So now I'm leaving it to Angel. to finish the presentation. Thank you.
Thank you, Brian. So yeah, that was just a quick overview on key things that we thought we might highlight. But overall, what I think is relevant is that we assessed that indigenous communities were not going to be included in protocols, key action protocols. Most of the content was being developed in Spanish. And what Brian was mentioning about indigenous communities not being familiar with concepts as quarantines, for example, made it clear for us that we needed to find an entry point to the key informant approach. The key informant approach at the moment was discussed as an entry point to find the key players at the community setting that needed to be mobilized, or that needed to have more information, or that we needed to account for in terms of knowledge, attitudes, and needs. So that's why we went to teachers, to midwives, to the frontline health responders, and the results are available at the Dataverse website. But what we found that is interesting is that our ongoing projects, we had phone directories for the mentors. All of the mentors that have participated in the girls programs that we implement here in Guatemala. So go back to 2005. That means that when we looked at the map, we had representation of the different indigenous groups just by having contacts that are regularly updated from these mentors. And so these mentors were an entry point to draw, other contacts around indigenous communities. And interestingly enough, these mentors in attitudes, practices, and knowledge share a similar profile to teachers and also to the community leaders that at the moment were not mobilized. So this information was key when going to the Ministry of Health, in particular, who's handling the response here in Guate, and asking them, so it seems that there's no protocol in place for indigenous communities, which is 42% of the population. And the answer was straightforward, that they are collapsed in the way they are looking after the places that report the most cases, which are urban settings, mostly the Guatemala City, which is the country's capital. And that some indigenous communities, the argument is that some indigenous communities don't have cases reported. So as of today, most of the cases are concentrated in the city. To us, that's just the regular thinking about the exclusion in emergency. So often there is no information about how indigenous communities experience these emergencies. So we don't have information about the availability of testing, even though people are aware of what they are expected to do. The possibility of going to a clinic to get a test is not real in these communities. And also in terms of the protection equipment for health providers, access to medicines, those will be challenges that we will have to leverage with a community roadmap or a community action protocol. And that's the relevant piece of this survey. This informant approach was relevant enough for policymakers to realize that a large share of the population was informed. It was expected to call the numbers that the government put out in case you have symptoms, but have no clue or no roadmap to act once cases are confirmed in localities near them. So we ended up working with the risk unit at the Ministry of Health, who is now working with us to see how we can identify a sample that is more robust, using administrative information, using other information that we can leverage from. And that is the piece that we wanted to highlight out of this, that in light of uncertainty about the size or the dimension of the problem with indigenous communities, we decided to go for a more qualitative, descriptive key informant approach that led us to speak to the right people that are still not talking about the exclusion of indigenous communities. And one final piece, I think, to us, it was key to work with our PGY colleagues. So Corinne, Twy provided a lot of input in terms of the approach we were going to take. And also we leveraged the hard work in terms of data processing with an intern that also Twy connected us with. And that was, it made things easier for us. So I would leave it at that.
Thank you, Guatemala team, Angel and Brian, so much for that presentation. We will now swiftly move to the India team, and Akash will present the presentation now. Akash, are you able to share your presentation?
Yes, do you hear me? Hello?
Yes, we can hear you.
And is my screen visible to all?
Yep, we can see it.
Okay. A very warm welcome
Akash,
to all of you. And yeah, we
can't
yeah,
hear you at the moment,
yeah, okay.
in case you're speaking.
A very warm welcome to all of you, and thank you for joining us today. In this unprecedented time, we all are at a fast learning curve, and where evidence related to direct and indirect impact of COVID-19 pandemic on various domains is crucial for policymakers and for timely management, mitigation, and future preparedness. My name is Akash Purwa, and I work at Population Council India Country Office. And at Country Office, we are working on a wide range of issues pertaining to COVID-19 pandemic and are engaged with various stakeholders, government, developmental partners, and donors. Just to give you a current scenario about India, India is now ranked 4th in terms of the COVID-19 infections, and we are right now at a mortality rate of 1.8 and with a recovery rate of 52%. Before I move forward, I want to give you a glimpse of the projects which we are right now conducting here in India. And the projects are divided into two, which is primary studies and the secondary studies. These are the projects which we are doing in to aid our effort and the efforts done by the Ministry of Health and several states and Central Ministry of India. So the first project which we are doing right now is on the knowledge, attitude, and practices, which is the project conducted in Bihar and Uttar Pradesh states of India. And this project is funded by the PC Institute. The second project, which is funded by the UNICEF Bihar and BMGF together, is a longitudinal cohort study, which in which we are assessing the situation of women, children in Bihar and Uttar Pradesh during the COVID-19 pandemic. This is not only limited to the situation of women and children, but we are also looking at the impact of reverse migration, the return migration, and how the livelihood and the economic repercussions of COVID-19 has impacted the lives of individuals living in the state of Uttar Pradesh and Bihar. The third project which we are conducting is on the health system response to provision of family planning services during COVID-19. As we all know that because of the disruption caused by COVID-19, and now the entire energy of the government is being channelized into the preventive measures for COVID-19. The frontline workers and the community workers are also being doing much more than their usual job, and their services are being shifted towards spreading the awareness of the outbreak, as well as providing services which are related to COVID-19. In such case scenario, there are regular duties which are more towards the services like family planning services or the maternal and child health services are being sort of deferred. So this particular project is trying to figure out what sort of constants and challenges they are facing, how the entire system has been disrupted. The next project which we are conducting right now is the USAID funded project under the evidence study, where we are trying to look at the market value supply chain system of the FP commodities and how the entire production has been sort of disrupted by this COVID pandemic. In terms of secondary data analysis, we are right now doing two types of analysis. One is the HMIS data analysis to understand the provisions of RMNCHS services and the nutrition services and how the entire shift has been done in the past for few months, to be precise, around 4 months since the time India first case of COVID-19 has been detected. Second study which we are doing is on the COVID-19 vulnerability mapping across states and districts of India, where we are trying to see that how different states and different districts are sort of reacting to this pandemic, and what sort of preparedness and management can be done based on the current vulnerability status. Moving on to the field level challenges. So while conducting this particular projects and the research, we found that because now we have moved from the traditional method of face-to-face interview, and we are more relying on the technology, and these primary studies are being conducted over phone. So broadly, there are four themes which sort of where we face the challenges. The first one is the logistic training and the technology, where because this was all virtually done, so how to do a coherent training, ensuring that a coherent training is being done, dealing with the technological bugs, how to do this sampling when we do not have a proper sampling frame. So though in India case, we were lucky because two of the main studies were sort of a panel study where the cohort was taken from the bigger Udaya study. So in that way, we were a bit fortunate. Then how to build the rapport and handling distress situation. Virtual rapport building and handling distress situation is something which is very crucial and important. So these were the few challenges, and obviously without in-person monitoring, how to monitor the quality data, how to maintain the privacy of the data which is being generated. These were few key field level challenges which we faced while conducting our research. Though with these field level challenges, we also worked innovatively, and we had some sort of risk mitigation strategies. Risk mitigation strategies we adopted to ensure the smooth conduct of field level activities, and also to focus on the quality of data. So like we did training in small batches with the interactive debriefing sessions, where we asked different investigators about their viewpoint of how we can improve the training. We did role play between the investigators, where one investigator became the respondent, another one was the investigator themselves. We had sensitization sessions on ethical consideration, consent and distress situations, how they can handle distress situation, how important the consent and how important is the ethical consideration while they are conducting the data. We also developed a protocol on how to recontact the respondents in case if they said that they have no enough time when we contacted first, or if in case their phone was not picked up. So we developed a protocol, and the protocol was adhered across the data collection duration. We also leveraged the existing cohort studies of sampling frame, like as I told you, like for example, we for getting the access to frontline workers, we leveraged another cohort of information which we already had at council from some other project. So those sorts of innovative ways we have adopted to get a sampling frame and to reach the ultimate respondent. We also developed a dashboard for daily monitoring and analysis to ensure data quality, because data, we had a limited time span and data was flowing in very rapidly. So we developed a dashboard to monitor that data, and all the data was obviously stored in a password protected server, so just to maintain the privacy across the data collection. Moving on to the dissemination and strategies and linking with policy, the one of the landmarks which we have achieved till now is that our family planning data results are being incorporated to the letter to Prime Minister for making FP as an essential service, and this letter was sent through the ARC group in India. There were several discussions which were held at the BMGF leadership in India for planning and investment to COVID-19, and our findings have been sort of our findings have been sort of used in their communication and other government counterparts. There were several platforms where we sort of showed our findings, which was COVID-19 risk communication and community engagement, Adaptation Future 2020 pre-conference, and there were several other webinars which were organized by UNICEF and BMGF. We also shared our data with several governments at both state and national level. Current current research which we did with UNICEF is also being used by their country plan and program to support government of Bihar and Uttar Pradesh in the assessment of their program outreach. In terms of the products which we have done, apart from the research briefs which we have seen from the first round of the survey, and soon you will see our next lot of research brief on various other topics, there were few sort of key products which we generated. One was the webinars which was organized, and this webinar was organized jointly by BMGF and Population Council. And this webinar was basically on how to collect high quality data during telephone surveys, using the telephone surveys during a pandemic, which is quite essential at this given time point, because that's the only board which is right now available to us. And just to mention that this was really a big success, where we have more than 500 participants who actually participated in this webinar. And as a result of this webinar, we are also generating several products. One of the products based on this webinar is the blog, which is written by another colleague, Vidubhushan. And this blog is about the mantras of ensuring data quality. So this blog talks about the 5 mantras of data quality, which is basically tool, time, technique, training, trust, and the topic. So these 5 mantras came as a result of this webinar discussion, and these are the guiding principle which anybody can follow while conducting a survey through the phone. There was another blog which is written by our colleague Trisha and Bidu jointly, which is on how to ensure data quality while collecting data during COVID-19 pandemic, again on how the phone-based surveys can be used in terms of bringing out quality data. We are also providing technical support to the National Institute of Medical Statistics, ICMR, in India, and we are giving hand-holding support in terms of how to conduct large surveys during a pandemic using phone technique. Recently, we also submitted a manuscript based on our analysis, and this manuscript is basically on the state and district level vulnerability for management of and response to COVID-19. We submitted this to Lancet Global Health, and coincidentally, today only we received the reviewers' comment, and they have invited us for the revised submission, and we will do that in next couple of days. Thank you.
Thank you, Akash. We will now move to the Kenya team. It's Karen and Tim.
Hi, everyone. This is Karen from the Kenya office. Tim and I are presenting today on behalf of a large team working on our COVID work. So I will share a little bit about our approach to research uptake, or making sure that our findings are used by a wide range of audiences. And then I'll turn it over to Tim to talk a lot more in depth about our work with the government here. Next slide. So it sounds cliche to say it. We say it all the time, you know, research uptake or dissemination starts before you actually do the research. But that is very much the approach that we took to this work. Initially, we reached out to the Ministry of Health and asked them in the very early days, first couple of weeks of, you know, after the pandemic reached Kenya, to say what they needed. And so we took and continue to take guidance from them on key topic areas for the survey tool. But to make sure, we also, you know, we've now done 4 rounds of data collection and are starting to expand into other sites outside of Nairobi. But before we develop the tool, we engage with the ministry. We ask them what the key topic areas are. They review the tool as well as other key stakeholders. So we've been working with somebody in the Office of the President, and she reviews the tools to make sure it's collecting the data that they need to guide sort of their policy conversations, etc. And then we deliver or develop a range of dissemination products so that as wide a range of audiences can use this information. So next slide, just next. So we start with a brief that's usually 3 to 4 pages that just highlights what the key issues are and sort of key breakdowns. And this also, we have the Ministry of Health review before we finalize it, so that the recommendations that we're making are actually seen as joint recommendations between the Ministry and Population Council. And then the Ministry feels empowered to take on those recommendations in the work that they're doing, particularly with community engagement. Next, we also develop a PowerPoint presentation that has a more visual, basically a visualization of the data in the brief, and we present this to typically to the Ministry of Health, and then at the community engagement level, and they often take 1 or 2 slides and then present it up so it's coming from the ministry to the National Emergency Response Committee, data on on COVID. We also have been doing similar presentations using these slides for the CDC in Kenya, USAID, and other partners, so that the data is getting out, and it's an easy way to share. When people say, what did you find? We usually typically send the brief and the PowerPoint together. Next, but also we wanted to reach more of a mass audience. So Tim and I did a blog post, a couple of, this was, I believe, after round 2, and we're gonna do another one after round 4. And then that blog actually was picked up by the next slide, please, or next, but picked up by one of the main TV stations. And so they reached out to us, and we did an interview and shared again the brief and the PowerPoint. And they did a really nice 3-minute segment on the research, and also talked about the importance of research, which was nice. And it was done in Swahili and in English. So it aired on the Swahili news and on the English nightly news. Next, and then we sort of distribute widely, largely the brief and the PowerPoint presentation amongst our networks, and then sometimes it just takes on a life of its own from there. So we've then found out, for example, that Dr. Eggers, who's the country representative for the WHO, gave at the end of May a presentation to all the development partners, and he lifted 5 or 6 slides from our PowerPoint presentation and just included them in his presentation. And so having the Pop Council logo on all slides, while sometimes seems extreme, actually in this case worked to our advantage. DFID has cited our data in policy briefs, and it's not even people that we've talked to, it just sort of takes on a life of its own. Next, and another example, somebody sent this report to me and said, hey, your research was cited in this is the UN Economic Commission for Africa, and did a case study using our data. And then also, last but not least, we've been working to try to also publish in the academic literature, so that we've covered sort of the full slate of audiences. So with that, next slide, and I'll turn it over to Tim to take it from here.
Thanks, Karen. So as part of our engagement with the ministry, I'd like to share just 1 or 2 slides on our experiences with working with the Ministry of Health, particularly the Division of Community Health, upon which the community engagement activities fall within the COVID-19 pandemic control and assessment. So within the community engagement subcommittee, it's actually ministry-led and chaired by the head of the community health. And within that, we have about 13 subcommittees clustered around population segments and geographical settings. And they are comprised of partners and organizations that do different things, but have an interest in community health space. The subcommittees meets weekly, culminating to a wider committee meeting once a week, upon which they send 1 or 2 slides on a weekly basis, and from next month it will be bi-weekly for input to the National Emergency Response Committee. So in this subcommittee, Karen participates in this gender committee. I head the monitoring, evaluation, and learning and research subcommittee, and also participate in the secretariat for the community engagement committee. So it's basically based on the principle of partnership and synergy, where partners with complementary skill sets and interests and geography in terms of where they work and whom they target in terms of population segments, really come together in these subcommittees, deliberate on issues, interventions, processes of how to support government, either at national or county level within the COVID-19 pandemic. It also employs a multi-sectoral approach where, for example, the Community Engagement Committee links with other sectors such as urban housing, especially when we did our first round of survey. This data was used by the Department of Urban Housing to begin thinking around how do they provide social and economic inputs to the vulnerable populations in these settings. We also link with the water and sanitation people to provide, both the hardware and software for WASH activities. The approach in which the Community Engagement Committee takes is quite adaptable in its response, because, for example, during today's meeting, we were thinking around how do we then evolve with the pandemic as it evolves as well. So looking at different needs of various population segments and in geographical settings, the National Emergency Response Committee always provides other activities that they would like support from the community engagement, and that is always rolled down to the various subcommittees to deal with. So our participation is largely within that community engagement subcommittee within the National Emergency Response Committee. What have we learned from this engagement? One is strategic position is quite key. PC has been engaged in various technical working groups, and under the Frontline Health Project, which Kenya is one of the countries supported by the Belinda Gates Foundation, we've been able to influence policy in a variety of ways. For example, we sit in the Community Health Technical Working Group. We're involved in writing the next strategy for 2020 to 2024. And within that context, the pandemic broke out, and we were someone to support the ministry in whatever capacity we have. And so we generated several subcommittees based on interest and skill sets. We've been providing relevant TA to government through these technical working groups, particularly to the Division of Community Health. One important thing in strategic position is think about relevant skill sets that are necessary to support the ministry and be in the forefront in agenda setting, and in terms of supporting the ministry, think what can we do here, what policies can be put in place, that it provides opportunity for creating a relationship. The second learning is it requires commitment to gain trust from the ministry. This can be done through various ways. As Karen mentioned, we have generated various quality products. We identified forums and relevant products for disseminations, and engaging different partners who then reach out. And as Karen said, it takes a life of its own after that. The other thing is constant learning on how best to work with government agencies, because they often come up with requests overnight. This morning, they just send an email. How much will it cost to do a survey in nationwide, for example? So having done this with the team in PGY, it's very easy to think around how many telephone surveys do you want to do, how many research assistants do you need, and it requires consistency and timely delivery of products, together with identifying champions who can voice your interests within the ministry and build alliances even within partners that support government. Other activities that we've been engaged, for example, that illustrate that is, very recently the ministry through the Community Engagement Committee were asked to put a budget for additional support from the Global Fund to support community engagement activities. So we were summoned again, the Secretariat for the engagement to, as a small group again, to sort of come up with a very quick budget that supports that. And the good news this morning, we saw an example of a letter from the Global Fund suggesting they might be able to fund the ministry on that. The other interesting thing and learning is aligning with government needs, be adaptable to changing needs of government, especially in the pandemic settings. Resources are often scarce, but often what happens is you provide TA relevant to that particular ministry. They see your role in it, even if you do not have resources. But if you create alliances with other partners who have resources for implementation, it's actually a key to success of the adaptation of the processes of implementation. Next slide. Next slide, please. Next slide. Okay, so this is some of the examples of outputs we've been able to support the ministry. The PC chairs this subcommittee within community engagement, bigger committee on M&D and research and learning. So we've been able to develop, partnered with ESRI and helped develop a map for all partners that are working in community activities in Kenya by county, by partner, and the type of activities they do. With the map is shown on your extreme left. We also developed a weekly tool that has been providing information from all counties by community health volunteers across the different counties that then submit data on a weekly basis on Thursday, and then we are able to update automatically the database on the right with which you can see on the bar charts. And that's basically done by community health volunteers who submit this data to our database. So we also have a similar database for partners who are working in community engagement activities report on the extreme right bottom left. These are examples of live dashboards that normally appear every week as partners submit their data. And recently we were asked by the ministry to support in community engagement, stakeholder engagement through CHVs, and therefore we able to generate very quickly data that was useful in developing home-based guidelines for isolation of patients with COVID-19. Thank you, and that's all we wanted to share from Kenya. Over to you.
Thank you, Tim. If we could, Corinne, yeah, if we could go to the next slide. We only have about 8 minutes left for discussion, and we will stay on for a few extra minutes for people who are able to stay on. We wanted to focus the discussion on the theme of research utilization and uptake, on how we can ensure that the evidence that we're generating, which is very varied, as you've seen from these 4 presentations on COVID-19, is utilized for evidence-informed decision-making. And we've heard some examples in the presentations themselves. And we're also seeing some questions, for example, and we've put some illustrative questions for discussion. We encourage everyone to raise their hands to ask questions. One question that Judith already has raised about what may be some of the best examples that we are already seeing, albeit you know, that we're in an early stage of our research in our countries to ensure that the evidence is being used and it's featuring the needs of vulnerable populations. So please raise your hands, and we hope to receive some comments on how we ensure that this happens. Judith, would you like to clarify your question in the chat box, if you wish, if you want to put more context onto that, that would be great.
Can I just unmute because I type horribly?
No, go ahead.
Yeah, so
yeah.
Just, you know, historically, this is an extraordinary opportunity, and congratulations to my colleagues. I'm always thrilled, just really thrilled with this organization. Some things are persistently resisted. We've had many engagements in which we did everything right, and there were either themes or specific populations in which there was intense resistance. Even if there was nominal, yes, do tell us. So, I mean, both the success, but any observation of the kinds of information, obviously the United States would be a good place to study, but we're not working there right now. The kinds of things you're learning that people aren't hearing, or the kinds of populations that they're not less interested in, and or we know and are tracking implementation challenges, e.g. reaching younger populations embedded in poor households. So just any insights there on how this information is moving along all the way to the ground, and whether we have mechanisms to follow it, you know, over time, because a couple months from now, I think it could be as interesting as it is now, which is great. To see those patterns of implementation will be extremely helpful.
Do any of the presenters from the 4 countries have any insights on the question that Judith just asked? And there's another question from John as well, along with that, on you know, we've conducted a lot of these surveys over the phone because of the necessity of having to social distance, but do policymakers have confidence in phone-based surveys, and what are they saying? Are they accepting it now because that's the only method we have, or are they expressing confidence in other ways as well? So we would like for our presenters or from other members of the team who are on the call to respond to both Judith and John's questions potentially.
To answer the John's question, like here in India, we are sort of generating that dialogue of how we can ensure data quality still by using the phone as a mode of interview. And as I mentioned, that we are trying to sort of make some guiding principles which can be adopted while one is conducting interview using a phone. Obviously, there are certain sort of constants, and when we move from the traditional way of in-person interaction, but it also depends on what sort of topic, like within this COVID-19 pandemic, what sort of topic we are trying to cover in the research, and how the interaction between the investigator and the respondent is happening. So that topic also plays a crucial role, which we are trying to cover, and those guiding principles will be helpful in terms of assuring the data quality if they are adhered to.
Ashish, can I say a few things from Bangladesh?
Yes, Dr. Ab.
Yeah, in Bangladesh, government is very skeptical about these small-scale phone surveys and giving information at the national level about several things regarding COVID, including the number of people are getting, all kinds of PPE and the way they were treated in different places. Similarly, the large-scale studies like 11,000 samples they have collected by BRAC and PPRC about livelihood and how people are getting help from the government. They are also skeptical that none of these samples are nationally representative, and these are selective samples where the phone numbers were available from earlier studies. So there are some skeptical observations from the government side in Bangladesh about these findings of these studies. I'll stop here.
Thank you, Dr. Rob. I think Judith's question is still quite important. I wonder if any of the team members in the four presenters or the four countries have any comments about Judith's question about how some of these processes are moving along, and if it may be that there are challenges, and you may talk about challenges as well.
Ashish, can I just give some reflection on Judith's question? I think one interesting dimension we've seen in the Kenyan setting is that the initial response to the need for evidence was quite positive in the Kenyan context. Perhaps the context of, we need information, we need this, we need to know what's happening. That has been the case over time. Two, we haven't seen any sort of less receptivity in terms of how they desire and use that information. The thing about moving forward, or maybe elevating issues of vulnerable populations to the policy space, I think the urban study that Karen was just presenting earlier on reflects the opportunity to be able to elevate these things at national level and for people to begin speaking about them. And from that, we've seen even UN agencies using our data to begin planning and thinking about how can they be able to reach these vulnerable populations. So I think what we don't know is how that momentum will be maintained moving forward post-COVID, but hopefully this is a window of opportunity to be able to begin influencing policy in that space. So I think that's my sense of it. Over.
Thank you, Tim. We'll stay on for 5 more minutes. So if there are any more comments or questions, we're happy to take them. Any comments from the Guatemala team on that question?
Yes. So, I think, and we discussed this in the past, the fact that we have always highlighted the need to make visible the excluded, which in Guatemala is 1 in 2 people, the indigenous setting. just served as an entry point for policymakers to start sharing more information. So we know there's no capacity at the current moment because of how everything's collapsed to pay attention to those details. To know that they need to develop a differentiated strategy that's effective for indigenous population, and the trust that they have on the council as a learning partner for other indigenous institutions in the country is allowing us to bring the approach to the Ministry of Health. So I think the one key element there is that we are not only bringing data, but we're also bringing the approach on reaching the excluded populations along the way. And I think that is relevant not only in the emergency response, but also in looking at other relevant sources of information. For example, the number of cases of domestic violence that are going up, not only for indigenous women, but for all women in the country. And that conversation also started with the information that was presented to these policymakers. So bringing in the approach that it's a key feature of the council is a value added in this stage, and I think it should keep pushing forward as we keep on engaging with policymakers.
Thank you, Angel. Since we're almost at time, I wanted to bring up another point that Soumya has raised in the chat beyond this discussion on research utilization and uptake, that we are learning that there are lots of interesting learnings around COVID-19 related science, about the operational costs and quality of our data and ethical considerations, and how and new methods, and how potentially we can plan for these in the future in sort of the post-COVID era. And I think it sort of requires it sort of makes us think as the council about how we can move forward in our research in the next months and years to come. We're really very happy to have participation from almost 100 colleagues from all across the world on this webinar. We are so grateful for your engagement with the Humanitarian Task Force. This is the first in a series of webinars we will organize around various themes and different kinds of research. And we hope that you'll join us in the future. I know that people have to leave on other calls, so we will end this seminar with a thank you to all of the presenters and the teams working on the ground in the 4 countries. We hope to feature work from other teams and offices in the future webinars to come. Please continue to visit our SharePoint and read our roundups, and we look forward to engaging with you in the future. Thank you so much, everyone.
Thank you. Bye-bye.
Thanks, everyone.
Thank you. Bye.
Bye-bye.
Nicely done. Thanks.
Thank you.
Thank you, everyone.
Thank you.
Thanks. Bye.
Thank you.